This is sort of an area that I've had very close to my heart for the last uh, like 14, 15 years is looking at orthoptist use and orthoptists and the profession of orthoptics and how to utilize them to expand access to care. Whenever I was in my training, actually being at Texas Children's and Baylor College of Medicine, I spent a lot of time, which traditionally with Gunter von Norton, I'm very much an advocate of orthoptists, but I didn't have an orthoptist in my actual clinical setting during my fellowship training. And I was very fortunate to have an orthoptist move to my community where I was opening my practice. And so I had my first experience working with an orthoptist in shortly after about a year out from starting up into private practice. And so one of the things that I've come to find is that orthoptists are so helpful, and it's really a way to expand access. And if using an orthoptist that's properly trained, I find is extremely helpful to then provide access to the ophthalmologist. And whether it's through sort of a gatekeeper technique, which some countries use orthoptists for more, you don't see the ophthalmologist ever unless you have seen an orthoptist, or whether it means the orthoptist being in clinic and then allowing you to, as a physician, to then see more new patients because the existing patients, many of which have amblyopia or strabismus, and they're non-surgical in nature, the orthoptist is fully qualified to manage those. So I got into a little bit more discussion of sort of what can we do to help and to address and look at this profession, because I think it's such an important plays such an important role as we're fewer and fewer of us, and at least pediatric ophthalmologists. It seems that our numbers are not growing. We're having a challenge filling what we do. There's more subspecialization within ophthalmology, and because of that, it creates challenges for how do we take care of all these patients that need us, that really need the specialization for what pediatric ophthalmologists do. Well, a solution is the orthoptist and optometrists. While I think they're a critical part to what I would call the TRICARE team of managing patients. I think it's sort of a three-pronged attack. Orthoptists has unique qualifications and unique aspects that makes them very helpful in providing better access to patients. So, with that being said, I'll just sort of preface that so I have no conflicts of interest. So again, this is sort of targeting for maybe people that don't have a lot of exposure to orthoptists, or maybe don't have an experience with orthoptists. Like why have an orthoptist? And I sort of hit on this earlier where I just talked about, it increases the number of patients that can be seen. And I'll go into some data just that I collected on my own personal practice. But more importantly, I advocate that it's not just the volume of patients that you see, but it's also the quality of care that you can provide. There's ways that we as physicians can see more patients, but the trade-off is at what cost, and what are you giving up as you're seeing more patients? You're missing maybe some of the subtle things that could reduce the quality of what you're trying to do. And speaking of quality, physicians that have orthoptists will say that an orthoptist makes the quality of our lives much better. And so that's an easy sell for those that have had orthoptists. So when we look at the model of sort of how we take care of patients, this is sort of, there's a physician oriented model where you look at the physician, you have these people that work under the physician, and the idea is that orthoptist sort of plays this role in the middle of this, but then we have all these pressures sort of onto us as the physician, on hospitals and government and insurance companies, on the pressure on us. But I tend to try to look at patient care more from a patient centric mindset. And when you think of the patient as the center of the care that we're providing, the idea is that the orthoptist plays this critical role in this actual sort of circular process. You know, uh, uh, there's a cycling through a physician practice. There's points when you as a physician could see the patient, but there's definitely times when you don't necessarily have to be involved in that patient's care. And this could be handed off, depending on the condition, either to an optometrist or an orthoptist. So again, it's all about trying to figure out and how to balance all these forces and how they act on us and how they more directly affect the patients directly. So the challenges of an adding orthoptists, really, I mean, the biggest thing is finding one. This is where, and I know in Canada, and also in the United States, the employment rates of newly certified orthoptists is nearly 100%, and then mostly many established orthoptists, that are established, they're convenient, they're already content, they're happy with where their location. So trying to get someone to relocate, it's not easy. And then I know that the Canadian training programs are going through some challenging ones where now there's only one training program left at Dalhousie University in Halifax. I know Darren's probably very, very busy trying to figure out, and the Canadian Orthoptic Council is trying to figure out ways to fix this issue. The big tie-in, and the reason why this is, again, it ties to the academic affiliation, where traditionally a lot of orthoptic training programs are established through hospitals, but because of sort of the governmental aspects of how things are done, there's this need to tie into an academic affiliation. So my understanding is there's a lot of creative ideas being considered, and hopefully this will help address that problem. So again, some people get into the cost of paying for one. I think that those that maybe have never had an orthoptist, they look at the price tag related to it, and this introduction of this new care model to the community, combined with the price, it's hard for them to understand and justify it. But once you do it, and then also have your patients and the patient population that you serve get used to and they get exposure, I find that they're inevitably very, very pleased. And actually, many times in my practice, the patients are upset that they're actually seeing me, because usually when they see me, it means that they've been waiting a lot longer. Whereas the orthoptist, when they're seeing the patient, it's a much quicker visit. So I actually, a lot of my patients actually don't like seeing me. They'd rather see the orthoptist because of what it means. But really, the practice dynamics, and again, there's variations between the United States and Canada, and sort of the level of supervision requirements. But the dynamics on how you take care of patients is a little bit different with the introduction of an orthoptist in the practice. But inevitably, the efficiency and the quality of care provided is improved. So depending on where you're at, it's trying to convince the practice management or the hospital system. Many of these large practices or hospital systems, they don't understand. There's so few orthoptists. They're not really well understood what they do, and really spending a lot of time in advance to lay the groundwork for them and really educate the practices, the health systems on what an orthoptist is, what they're capable of doing, what their certification means, and creating almost this understanding of the value for the institutions. And really, that's that defining of that role of the orthoptist really, really is important to try to introduce them into a setting where they hadn't been before. So I do think of an orthoptist as a mid-level provider, and this is a sort of a lot of discussion where they do, in my mind, fall into the realm of a physician assistant, a PA, nurse practitioner, and it's all related to their graduate level training that they have, and what they go through to become. And this is me speaking as the past president of the American Orthoptic Council. There's a lot, and the expertise and the written and oral boards. It's quite a feat. So the expectations and the continued medical education requirements really keeps them in the discussion, and they should definitely be considered mid-level provider. I think Canada is ahead a little bit in how they perceive the use of the orthoptist. In the US, it's a little bit harder sell for some of the hospital systems for them to understand what an orthoptist does and what it can provide to the care that you provide to the community. Now, that being said, orthoptists, but they aren't PAs and they're not nurse practitioners. And there's important sort of qualifications that what separates them. But they are the mid-level providers for a pediatric ophthalmologist and pediatric ophthalmology profession. And because of that, they hold this critical, integral part within the pediatric ophthalmology and the cares that we provide. But in many countries across the world, and the IOC, International Orthoptic Council, the profession of orthoptists is expanded in many ways beyond the field of just pediatric ophthalmology. And you're seeing them used in many, many different areas outside of our area in research, glaucoma, retina, because of their unique training and their expertise. an understanding of the visual system. I would arguably wish that orthoptists were more involved with some of my retina colleagues, because this whole sensory understanding they tend to sometimes miss. But anyway, so to understand sort of like mid-level providers and orthoptists, a lot of my talk is talking about the United States, but I think that the idea behind this is that it sort of gives us a better understanding of maybe the pathway that orthoptists and what the profession could look at and take into as we move forward into the future. Because of the challenges of access to care, they're only getting more and more challenging, and the ability to take care of our patients and provide those probably at the most vulnerable becomes harder and harder. So in the United States, this CMS, which is Centers for Medicare and Medicaid Services, they're the entity that controls a lot of the billing and collections, the reimbursement for the care that we provide for patients. They have defined specific unique roles for like a midwife, a nurse practitioner, and a physician assistant. But the way that orthoptist is recognized for CMS purposes is not at that level. And because of that, their medical communities, they're really only in the community setting are they defined more as a mid-level provider, which orthoptists would play under. So this goes into the DA classifications in the United States, which is it shows basically what a non-physician mid-level provider would include. It includes, outside of dentists, vets, and podiatrists, they're licensed and they're registered. In addition, and permitted, which implies certified to submit a controlled substance. So in the United States, to be a mid-level provider, it allows them that ability to have controlled substance use, which is why these individuals fall in it and why an orthoptist does not fall within that realm. I would argue that optometrists in there, I'm not sure why they would be dispensing controlled substances, but at least in the United States, that's sort of what they're looking at. And then if we look in Canada, this definition of what an orthoptist is defined is actually through the National Occupational Classification. And they are actually included, this is where I talked about Canada being a little ahead, and they're actually included within the physician assistants, the midwives, and allied health professionals, but orthoptists are included in that classification. So for Canada, at least, the understanding and use of them as a mid-level provider in the traditional sense, Canada's ahead of the game as far as use of them. Where Canada is behind is where we're trying to, which is a lot of the United States is too, is the production, the training of enough of them to get them out there to fill these roles. And really, and that's really where we're trying to go. So if we look at the history of like non-physician providers, at least in the United States, the purpose of this was, again, it's to develop healthcare to remote populations. And the initial use of these non-physician providers in the United States were based upon other parts of the world, such as in the wilderness of Russia and rural China, and then frontiers in American Indian villages in Alaska at times of war, and then also in the prison system. This is where physician assistants in particular were first introduced and sort of utilized. And so I talk a little bit about sort of the non-physician providers, specifically physician assistants, and how their profession grew over time, because I do think that may be a model of where orthoptists could grow and the profession could grow over time too. So if we look at physician assistants, the first actual physician assistants, it was actually birthed in North Carolina in the 1940s. And there was a general practitioner who had an employee, his name was Buddy, and he actually called him as his doctor's assistant, but he actually provided care when the doctor was out. And he became, this is because the use of this doctor's assistant to be used widely used in a lot of rural areas of North Carolina. And then in post-World War II, there was a shortage of primary care physicians because of war, and that created an increased interest in these non-physician providers in the United States. In 1957, there was a program to train nurses to assist physicians that was started at Duke, and it shortly after failed, but it created this visible model that the AMA made note of. And in 1961, there was an address to in the JAMA article called Expansion of Medical Professional Services with Non-Professional Personnel. And so this is one of the first big articles talking about sort of expanded access to care and use of medical providers. And this is where that term was actually first used, was in that address. The World Health Organization shortly thereafter began recognizing non-physicians as potential providers of healthcare. So then we go into 1965, and this is when Medicare and Medicaid was created in the United States. And this creation actually was a good thing, and it provided increased access to care. But we had to have more providers to provide that care. Hospitals were desegregated, resulting in restructuring. The first nurse practitioner program was actually started in Colorado, and then Duke actually started their first PA program again in the mid 60s. And then if we look in 1970, Kaiser became the first first HMO entity to employ physician assistants. And then in 1971, there was a Comprehensive Health Manpower Training Act that authorized federal funding for PAs to be actually educated. And this created a tripling, of the PA training programs in the United States. And that is one of the challenges and one of the issues in the United States as far as orthoptic training and training programs, is the training programs are not tied directly to access to federal funding. And that is one of the limiting factors, is for the expansion of the profession in the United States, is having access to funding for federal loans to then be able to offset some of the costs of being in orthoptic training school. So that is an area that I think there's a pathway to get that changed, at least in the United States. And in Canada, I'm unsure about exactly how funding goes, but I'm sure there's similar issues. That probably is why this switching over to an academic affiliation is needed for the training programs in Canada. In 1986, there was reimbursement to PA services actually was allowed under Medicare, which in the United States, unfortunately, it seems that things that are changed, they're more driven by how you get paid. And if you don't get paid to do certain things, things don't change. So reimbursement is a big part, and it actually is what will help push non-physician providers and the use of them farther along. In that time in 86, the hospitals, nursing homes, and surgical assisting were able to utilize and bill for PA services. And then in 1997, the Balanced Budget Act authorized PAs to consider them as covered providers in all settings, not just in Medicare and Medicaid. So that allowed private insurance to actually utilize them, which also further expanded PA use. In 2000, Mississippi became the last state to authorize PAs to practice. Each state, although in the United States, has its own legislation that defines the scope of PAs. There are some that are able to independently operate. Many still, they operate under the direction of a physician. But the 2010, President Obama signed a Patient Protection and Affordability Act. This allowed additional patients that, and specifically Medicaid, and into the insured population in the United States, which then only created increased demand for these mid-level providers. 2014, the VA system updates its policies to expand use of PAs. Then Congress authorized the use of PAs for managing hospice and Medicare patients. And then in 2021, the COVID pandemic created increased vaccination authority passed on to PAs and students and retired PAs because of this increased demand to provide care. And then in 2022, just last year, the CMS changed its repayment policy so that PAs can be reimbursed directly, which expanded them to have more independence, which has its own pros and cons. So then if we switch and transition, this is where I'm not as thorough in my discussion, but a little bit more on the history of non-physician providers in Canada. We know that 84, the Canadian Armed Services adopted the term physician assistant as the role for senior medics. And then they changed in 91 this to actually from senior medical technicians to the word physician assistant, which then changed the dynamics on the PA's use in Canada. In 2003, the CMA recognized the PAs were unique health professionals. And then in 2014, they were given prescription rights in New Brunswick. And then in 2016, uh, CAF was patients and the CAF were commissioned to the status of officer, which also changed their use. We look at orthoptics, the profession in Canada. In 1937 was actually, again, we talked in the previous discussions, was Mary Maddox and her influence in London in 1930s, early 1930s, as far as starting the orthoptic profession. And it wasn't shortly thereafter that the first Canadian orthoptic clinic opened in Winnipeg in 1937. So orthoptics has been in Canada like it has been in the United States for a long time, over 75 years now. But in 1940, Vancouver opened its first training program. And then 1967, the Canadian Orthoptic Society and the Canadian Orthoptic Council were founded shortly after the American Orthoptic Council was actually initiated. Now, PAs have paved the way to gain better access to care, and the part of this discussion is really that orthoptists can also pursue a similar course. But the key thing is, you can see, is it takes a lot of time, and a lot of it is a product of demand and need for improved access and improved care with limited number of physicians to be able to provide it. So the way that we're going and the direction that we're going, there's going to be some professional, somebody that's not a physician, some non-physician provider that's going to end up filling this gap. And orthoptists are in a prime position to be able to fill that role and to fill that gap. Although we have to also be mindful of optometrists and how they are also expanding in many parts of the world, their profession. And again, it's driven by access related care and being able to provide care to populations that don't have access to an ophthalmologist. Orthoptists, I would argue, a better understanding on the visual system and the visual development, at least in the United States in general. There are some that are very, very good with their binocular vision understanding, but in general, I find orthoptists are more primed to help manage not just the pediatric population, but also some of the adults with the unique problems that I discussed before because of their unique knowledge in sensory motor fusion and that. So the value of an orthoptist. This is really, for those that have an orthoptist, they get this. I like to break things up into this direct value and then also this indirect value. So if we look at the direct value, this is where most people that are administrators, most systems, they look at, it's like, okay, well, how many patients can you see and what was the orthoptist allow you to do? This increase in patient volume and the increase in patient care and the number of patients that are getting services. That's what I would call direct value. But there's this indirect value, which I feel people fail to understand. And that's where I spend a lot of time when I talk to my American colleagues of getting them to understand the value of an orthoptist is that, you may get reimbursed, less for patients that are seen by an orthoptist. But the value is that it's the new patients that you're now able to see. And because those patients that are seeing the orthoptist are no longer filling up those spots on your schedule. It's that new patient slot, the new access to care, the expanded access to care, which actually generates the true value of the orthoptist. And that the more new patients that you see, the more that you expand and provide better care to the population, the more some of these patients are able to be surgically managed because the patients that don't need you, they get cycled either to another general ophthalmologist and optometrist or orthoptist, and then you focus more as a pediatric ophthalmologist on the actual new patients. The other thing is that my orthoptists historically have been very involved in my research activities and then very, very helpful in providing good, well understood research opportunities. I found that there's even orthoptists in a lot of studies, research studies, that private companies are actually hiring orthoptists to run the research aspects of their studies because of their knowledge and understanding of clinical care for the patients in our population. And as I mentioned before, this indirect is this, for those that practice in the United States, surgical revenue is definitely increased by having an orthoptist. again, driven by the new patients that you're seeing. So an example of my typical practice of what I have is one orthoptist with two technicians. I average with this kind of scenario on a slow day, maybe 45 patients a day, but some places I know that they see quite a bit more. I average about 12 surgeries per week. And whenever I compare this to other pediatric ophthalmologists in my own practice that don't use an orthoptist, I know that I have at least 30% higher surgical volume, and my collections are 20% higher just by having one orthoptist. Historically, I've had two and a half full-time equivalent orthoptists at one point. I was building an army, so to say. People jokingly told me, but that was almost it was I was getting so many patients, and and it's really the as you increase your volume in patients and orthoptists, there's this other aspects of patient care that isn't direct patient interaction, more behind the scenes when you're at your desk going through and getting caught up on other activities. When the more orthoptists you have, the more non-patient care direct time you need to be able to manage all those things and reviewing charts and things like that. So I have scaled back. Some of it was a product of the pandemic, but to do one orthoptist. But again, if I had patients where I had a situation where I had one of my, like an orthoptist that was out on maternity leave, and I could see sort of a pre 9 months of not having orthoptists, and one of my orthoptists, and then the post, and I had to be able to compare the information. And I know that whenever I had my orthoptist, my patient visits for this first time use of an orthoptist increased 12%. But and again, this is my first orthoptist, increased my surgical volume 40%, and my collections again about 22%. But overall, if you add the surgical, because in the United States, the surgical reimbursement is actually better than the office visits. My overall collections increased with just the addition of one orthoptist by 43%. So I did send out like a small survey several years ago to a small collection of pediatric ophthalmologists, and just to kind of get an idea about orthoptists incorporation into their practice. Do they have one? Do they not have one? How many do they interact with? And just wanted to share some of these results. So again, there was a small sample size, but in general, about a third had a full-time equivalent, and then there was about a third that had two of them, and then none for the small amount. So this was a group of mostly that had orthoptists. But then the question of in the United States, at least, this is where they were sampled, did your orthoptists have their own patients or their own clinic? And that's where I found that, yes, they do both, but there was more people that ended up having them concurrently in their clinic, combined with having their own clinic, the orthoptists having their own clinic. And my understanding is Canada, there's a lot more of orthoptists having their own clinic, which is a great way to improve access to care in communities where maybe a physician can't exist and stand. So then I guess the next question I asked was who directly sees the patient in the clinic. The physician and orthoptist sees the great majority of this sample, and only 12% of the patients only saw orthoptists. And then in my practice, I would say it's probably higher on that sense that I empower my orthoptist to try to do more and manage more, just to provide better flow and also better care for me. So again, this productivity survey, I found that 27% reduce their clinic volume when the orthoptist is out. 20% of orthoptists have a technician that actually assists them when they're having their own clinic, which only improves the efficiency of the care that they can provide. And then 10% of the physicians that I interacted with in the United States, they are able to negotiate with private insurance carriers for special reimbursement for the care of the services provided by orthoptists. So we look at overhead and profit of orthoptists in the actual practice. Average overhead of a pediatric ophthalmology practice is 58% of this overhead. The amount allocated to an orthoptist salary on average maybe is 10%. But then if you look at the collections, again, both indirect and direct collections, the survey found that about 26% of their collections is attributed to having an orthoptist in their clinic. And but many weren't able to fully answer that question. So if we look at access to care, providing access to care to those in need should be the focus of what we do as either as physicians and then also those mid-level providers. And the access to care in a timely manner is becoming more and more challenging for children and adults with very big eye care needs. And I would advocate that the orthoptist is a great way to expand access and also help streamline the patients to the ophthalmologist more efficiently. And this triaging of these conditions, and so that the more urgent situations get to the ophthalmologist more quickly. And then again, orthoptists can provide this special care to outlying communities where there is no practicing ophthalmologist. So moving forward as a profession for the orthoptist, the goal of the profession orthoptist is really to continue providing this quality orthoptist. And this is one of the things that I just really try to emphasize is that there really should be no shortcuts. There should be no lessening the standards of what we want orthoptists to be, because that only weakens what I feel the profession can grow and become over time. We need to do more in educating those about what an orthoptist is. Education of what an orthoptist is creates an understanding of the value. And then as we have value increase, it improves the ability to incorporate practice management into the continuing education curriculum for a lot of us as physicians. And then promoting the profession despite the shortage of orthoptists. This is where the pressure of seeing and taking care of our patients is what's going to drive change. And continuing to promote the orthoptic profession will be critical, because understanding and realizing that they are a source to help be part of the solution to this problem is going to be critical. So moving forward, this is where the collaboration with all these other organizations that exist that deal with patients that we take care of, and creating this network. And this is where I get into the sort of my other hat of organized medicine, and understanding that you're not going to be able to do this alone. We're not going to be able to do, whether it's the American Orthoptic Council, the Canadian Orthoptic Society, by themselves, it's not something that's attainable. But when you partner and you collaborate with all these other organizations, and that's not just ophthalmology, but medicine in general, and you understand and you collaborate with them and introduce and bring more orthoptists into those entities to either give talks or presentations to gain an understanding of what they are and what they can do, it only creates more value to the profession, to hopefully then use this as a way to leverage and incorporate this as part of the solution as we go forward. So that is sort of my talk on orthoptics and expansion of use and use of them in the communities. I'd love to talk more about this and hear what others sort of think. And I know that Canada is having some challenges, but also I would say trying to be optimistic and trying to think of solutions and ways to work around this will be the important way to go forward. So thank you.
Thank you very much, Dr. Miller. Yeah, very interesting talk. Yeah, really, we're kind of at a crossroads right now in Canada, trying to figure out exactly who we are as a profession and looking to promote ourselves more and to gain just a better understanding among the eye care community about what we're capable of doing. I just have a question here from Dr. Bugles. In relation to the impact orthoptics can make in a patient's eye care, how many post-operative, so corneal laser, cataract, or retinal surgery patients do you see that had an underlying binocular sensory condition that was unrecognized preoperatively? Should all of these patients have an orthoptic review preoperatively? It seems this would help in patient selection and in establishing better patient and physician postoperative expectations.
That's a great, and the quick answer is absolutely. That would make a whole lot of sense. The only challenge that I always say whenever I have this come up is that there's two angles that you look at this. So one is the number of orthoptists and the time that they have to be able to do this. And this is where we have so many patients that have this condition. And if it was my family member, I would have them maybe see an orthoptist beforehand, assess this. But again, it's the ability to access an orthoptist. And then if an orthoptist is doing this, then they're not maybe seeing kids or not being able to do these other things that they're so capable of doing. So it's really the trade-off and the ability of access, and do you have enough of them? I think that it's in a perfect world. This is where I get into discussions with optometrists all the time. In a perfect world, every kid has a full eye exam, but really there's not enough of everybody to do this. And for at least in the United States, too many kids get optometry evaluations and get glasses that are not needed, which is a waste to the whole financial use in the system by itself. But getting back to what you were saying, absolutely, that I see a fair number, but at the same time, I keep in mind that you have to think of the patients that come into those that do see adults and deal with double vision and binocular vision disorders. We're seeing patients who failed the system that either didn't or were having problems that have these issues, but we're not seeing probably the vast number of individuals who had a hugely successful refractive surgery procedure done. And so there's a little bit of a selection bias when we have those patients come to us. The whole discussion of monovision and some people that have this monovision procedure and they have it addressed. I'm always hesitant to try to not pass too much judgment because yes, it should be part of it. It should be part of their assessment. The good ones that do a lot of these, they do incorporate some level of sort of history and binocularity assessment part of these procedures. But even the bad ones, I would say that they're still good in the results that they get. And all we're seeing are the ones that slip through the cracks that either were missed or come to us. So which can be some of our more challenging patients that we have as pediatric ophthalmologists who manage adult strabismus. So again, keeping in mind the selection bias, absolutely, I get a lot of those patients that you just talk about. The first thing I'm doing is getting them out of monovision, and then reassessing after monovision is taken away the situation. But I also know that there's a lot of people that have these procedures, and a lot of people, an overwhelming majority, are very satisfied with the results. So it's a little bit of a sampling bias situation, and then also number of people that can do this and the access. And if they're doing this, what are they not doing it as an alternative? Because there's not enough of them.
Dr. Rubab, I think you were next.
Yeah, I will just second whatever Dr. Miller said, and I truly appreciate orthoptic services. I cannot imagine having a pediatric ophthalmology practice without the help of orthoptists. So from triage to preoperative assessment, postoperative care, in every aspect of pediatric ophthalmology and adult strabismus, I feel their services are great, and I'm thankful for that.
And I would argue that the situation of what y'all are going through, I mean, it's just a critical thing, because if we don't get a solution, at least in Canada, on how to address this training issue, it's only going to hurt us as physicians. It's only going to hurt us as physicians to be able to provide that care. And I can tell you that there is no way that I could see adults and do adult strabismus in the United States in private practice without an ophthalmologist. There's no way financially, no way time-wise that I could come close to pulling that off. And so truly having an orthoptist in my practice, in a private practice that has, I do some academic stuff, but my practice is a private practice. It's impossible to be able to take the time and gain all the data that you need to manage a lot of these adult strabismus patients without having one. So yeah, I think it's a great point, and got to keep pushing for understanding education of what they do.
Yeah, there's a large gap in the knowledge and skills that an ophthalmic assistant will have and that orthoptist will have, and this is very difficult to our health region people to make them understand how they are different from ophthalmic assistant, and they cannot replace orthoptist.
Yeah, and this is where my experience when it comes to patients who have been involved with an orthoptist, at least my orthoptist that I've had, there's hesitation at first, but once they interact with the orthoptist and they start, I mean, there's no, I can tell you the number of patients that I've had that have seen an orthoptist and then did not want to see the orthoptist again and wanted to come back and see me instead was like less than I could count on my hands. Okay. There is a lot more people that see me that don't want to see me again, that they want to just see the orthoptist. And so it just goes to show that once you get exposure, and this is where, the leveraging, and this is where, you look at who makes these decisions and this is where you find those unique advocates out there in the community, whether it be people that had, similar to, the Kaye family and the unique problems that their child had that created this whole understanding. You have these patients that are adults that are maybe in positions of decisions, that whether a hospital system, and you'd be surprised there's those that interact with those that are part of the decision-making process. You build that relationship, even though you help them, but also utilize that so that they understand what an orthoptist does, and then their understanding grows, and then you use those people with their own personal experience to then hopefully grow the understanding it to their colleagues that make the decisions, and hopefully get things to change.
Dr. Aragutna.
First of all, Dr. Miller, I'm really impressed by your knowledge of the history, not just ophthalmology or orthoptic schools. Everything, even though I've been in Canada so many years, I wasn't aware of the first school or first orthoptic clinic. So that's very impressive that you take an interest in the history. And the second point I want to say is actually, unfortunately, this is on Zoom, and you were not able to come here in person like the previous years. But if you came here, you would have seen that my colleague and myself, we're actually in an adult hospital. While there's a children's hospital right across the river, like from our pediatric waiting room, you can see the children's hospital right across. We're that close. About 15, 20 years ago, there was the idea of making a children's hospital here. They were collecting donations. Dr. Rubab and myself met with the administration people about 15 years ago. We tried to explain that we are pediatric ophthalmology. By the way, we're the only two for the whole province who do full-time pediatric, mainly pediatric. And then Dr. Bugles, who's on this session here, he's a comprehensive ophthalmologist, also does some pediatric. And the only comprehensive ophthalmologist I know who has an orthoptist in his practice. So that's good encouragement for orthoptists. But what I'm trying to say is we were unable to convince the administration how important it was for the ophthalmology part of the clinic to have long lanes that are 20 feet in distance, and to have an orthoptist with us on site, right next to, as much as possible. Unfortunately, it didn't work out, and to this day, we haven't been able to, despite being pediatric ophthalmologists, we haven't been able to get a space in the children's hospital, which is very unfortunate, partly because they didn't realize the importance of pediatric ophthalmology, and that orthoptists and pediatric ophthalmologists, we function as a unit. This is despite some of the people in administration bringing their own children to us. Yeah. We've operated on some of them, we've treated them, and they've tried their best. But when it comes to dollars and cents, they were like, can orthoptists work for, say, when the cardiologist is in clinic, or ENT? Can your 20 feet rooms be used by ENT or some other? They were always trying to see if they could, reuse and repurpose the resources. And unfortunately, we're still to this day in the adult setting. So,
well, and yeah,
advocating is good.
So what you're described is a very similar scenario for many places in the United States too. So it's not unique to you as, in Canada. But what I find is that there is again, this is where understanding the value and being able to quantify the value. This is where if there was efforts to try to give better understanding of the value of the orthoptist, it's actually trying to give them like a numbers understanding. And this is where too many places that I interact with, they look at, okay, the raw numbers. Okay, well, what's the orthoptist seeing? And then in the United States, okay, how much are you billing for those services the orthoptist is seeing? And they just look at the pure number, and they're like, well, you're barely paying for the orthoptist. And I'm like, but what they're failing to do is failing to understand the access and the new patients that are now, those patients are no longer in your schedule. So yeah, you may not be making as much if you'd seen them, they maybe get paid better. But it's the access and the increased new patient volume that you gain by having an orthoptist. And that's what I would call more of the indirect value. And And I know a lot of hospital systems fail to understand that component, that part of access. And the thing is, it really comes down to when the worse things get and we have more and more patients that we're expected to see, there's going to come a point where we can't see more patients. We can't as pediatric ophthalmologists. And it's either going to be pushing people that, which is the unfortunate thing that we have is people with amblyopia that they're getting in, a year later than where they should have if they had just been seen, and then you have a bigger hole to dig, and then the costs of the increased amount of care it takes because they couldn't get access real quickly. So, this is where, again, hopefully education and that putting the value onto those aspects of the value of it's more preventive care, in a sense of when people have been successful in giving evaluation to preventative care, but having an orthoptist, I think of it almost as just quicker access so that the problem doesn't get as big, and then you're not dealing with as big of a problem. I mean, these people that have amblyopia and then get sensory strabismus that end up or needing surgery after patching, you could argue that, well, they may not even need surgery if they just had seen the orthoptist in a timely manner, started getting vision recovery, and you save money there too. So how do you quantify that? That's where you have to look at some medical economics people involved and design some things to try to then publish and then educate. So.
Any other questions or comments?
I was going to commend you for the general ophthalmologist that found an orthoptist. You must treat him really well.
Yes, Todd, we love you. We appreciate.
I'll put my video on. I'm at the cabin, so I'm kind of unshaven, so I apologize for that. I should say that I found Donna actually when I joined George in '96. He was a comprehensive ophthalmologist from Glasgow, Scotland. Came to Prince Albert in 1968, and so he always had orthoptics in the house and had a long relationship with the orthoptic department in Saskatoon. And so I was very fortunate to come into that situation and being mentored in Saskatoon within the department, and orthoptics having the program at the time certainly had an impact on myself. And there was a brief moment where we had two orthoptists in Prince Albert. So it's been a very rewarding association that Dawn and I have with each other. And yeah, echo all those kind comments, Dr. Miller, that the patients really feel included in their care.
Absolutely. And just having, it reminds me of whenever I talk to residents and the places that have an orthoptist, how much of a ophthalmology residence training is actually from the orthoptist on the pediatric side. It's pretty remarkable and you can see such a difference by those programs that have an orthoptist involved in education of the ophthalmology residents and their understanding of strabismus and that's not a knock against those that don't, but in general, the residents that are good at it, I'll ask them and they see my orthoptist that's who trained me, and so they play a big role in many different areas, but most underlooked is the value of the education side that they play a role in, which influences people like you, Todd, and how that it changed you and what you wanted to do, just your influence by being exposed to them.